Quite often to athletic activity, but any repetitive activity or activities that generate significant, again, using the word stress on a localized area of the body could then result in a stress fracture. That's the primary way. In fractures are of many types, and when we're speaking about fractures, we're talking about breaks in the bone where the continuity of the bone is disrupted. And so that would be, if we were to see it on X-ray, a complete fracture, or in the context of what we're talking about, where these are stress fractures. The archaic term is an incomplete fracture. So when we take care of those complete fractures, if we've known anyone who's broken a wrist or an ankle, generally speaking, we immobilize that area and we create a context artificially where that area can be rested through casting or through bracing. And similarly, along that spectrum, then if we were to look at an incomplete fracture, the same principles apply, where we would encourage rest, immobilization to allow the body to heal itself. Treated with rest and immobilization, and then the radiographic signs of that fracture have receded or regressed, then essentially we could say that potentially we're starting from a baseline. However, if there continue to be radiographic signs or even clinical signs of injury, then we have not returned to baseline. And if that athlete were to resume the activities that precipitated the injury initially, then of course we might look at that as a re-injury, but it's really the continuum of having an injury that hasn't been fully healed. Stress fractures, surgical treatment becomes a factor if that stress fracture progresses to a complete fracture, or if it's what we would say refractory to the conservative treatment, to immobilization and resting. If it continued to be symptomatic and continued to create those clinical signs that represent the injury, then surgical treatment certainly is within our means to help the athlete return to activity.